So good afternoon all. So I'll be speaking on something that all of us have had at some point of our career. If anybody is saying I don't have this complication, then he must not be an ophthalmologist. So management of PCR. So why are we scared of PCR? Because it can lead to increased risk of all these complications, right? CME, vitreous hemorrhage, or RD, at times GRT. But most of the time these complications are there not because of the PCR but because of the panic reaction that sets in, and you land up in doing a lot of things which shouldn't have been done. So my videos are basically based on that, what shouldn't have been done and what could have been done. And nowadays with this panic reaction and complication, we can add one angle, medical legal aspect. Now patients are very fond of filing cases when something goes wrong. So management of PCR involved, you should be ready. So we all have had such experience that we are shouting at the sister, ki, get me the cutter. You are asking your assistant, ki, give me a 3-piece IL, but it is not available. So whenever you see these risk factors like posterior cataract, high mature cataract, brown cataract, or you are not that expert enough and doing Phaco, then you should be prepared with all the setup that is required for managing PCR. If these risk factors are there, you should be careful while approaching your, especially for beginner, the last pieces or doing a soft cataract or any step. Okay, so early recognition is the clue. So these are the signs, and most importantly, loss of followability. You can see a transient glow, you can see the tip is getting blocked or partial distance of the nucleus. These are the signs that is important to recognize early. So what if a PCR occurs? It two factors determines what should be done. One, whether vitreous is there in AC or the hyaloid is breached. Second, what are the size of the nucleus. If vitreous is not there, hyaloid is intact, nucleus is large, you can extend it and deliver it. However, if the piece is small, you can coat the area with viscoat and do phacoemulsification using lowering all the parameters like vacuum or flow, everything. If vitreous is there, you don't have a choice, you have to do a good vitrectomy, and then you can approach similar to earlier, as I said. If it is large, deliver. If it is small, you can go ahead with Phaco. The third most important factor in this, your expertise. If you are not good enough in phacoemulsification, you don't have the experience of doing a lot of cases, it's better to convert. So I'll go through a few videos. This video is what you should do immediately whenever you land up in a rent. So I'll just come here. Okay, so now here see last pieces, the surgeon is trying to get it. The moment the assistant hydrated the cornea, you can see there is a PCR. So the catch here is always come out with your second instrument first. Don't take out your Phaco probe in a panic mode because it might have some vitreous strand. If you pull it immediately in a knee-jerk reaction, you may pull some vitreous strand and cause some RD or some tears. So that is the catch here. And second catch is here, always keep your assistant happy because you can see the cornea is quite dull because saline was not put and the surgeon was little bit blurred. The moment the saline was put, he could see there was a PCR. The second is vitrectomy. Whenever there is a PCR, you have to do vitrectomy. So if you feel the vitreous is there in antechamber, don't go with the IA cut mode. Basically, there are two modes. We all know cut IA and IA cut. Always start with the cut IA mode. So first cut all the strands and then try to aspirate. Once you have done that, you can switch on to the IA cut mode so that you can take out the residual cortical fibers. So what if PCR occurs early in the surgery? So if you are not expert enough, it's better to convert. But as I said, people do some certain things in a panic reaction. This was the case of classic capsular block syndrome. Chamber was filled with viscoelastic helon and the rhexis was small. When you inject fluid, the fluid had only one pathway to go, that is your PC. So it ruptured the PC and went behind. However, as you can see, the surgeon couldn't identify this sign and a lot of attempts were made. Some even, I don't understand why these things were done. So ideally would have been, this was a completely big nucleus. So it could have been delivered by enlarging the wound. But the wound was not enlarged and all attempt was made just to know what happened. And by the time the surgeon realizes, the nucleus was already into the vitreous cavity. So this is important. Early recognition is a clue. If you don't recognize early, then you will be in trouble. This is a case contrast to that. Here the surgeon could recognize quite early that there is a PCR, if you see here. So there is a transient increase in the glow here. So now the surgeon is injecting viscoat so that the nucleus is being shifted to a safer place rather than the area of PCR. wound was enlarged and the nucleus was taken out. So this is the right approach whenever PCR occurs early in the surgery. It's better to enlarge the wound, do a good vitrectomy, and depending on the availability IOL, you can put the IOL in the sulcus. So this is another video of nucleus drop. Here again you will see the almost half of the nucleus has been taken out. There was a PCR, and the ideal thing would have been, since the rhexis margin is there, bring out this nucleus to a safer area and complete either Phaco or deliver it. However, an attempt was made using the Phaco probe, using all the parameters high, so that somehow to catch the nucleus and take it out in toto, and ultimately the vitreous and the nucleus went inside the vitreous cavity. So such reactions should be avoided. Whenever there is PCR in early stage, it's better to convert and deliver it. So what if PCR occurs once you have already chopped few pieces? As you can see in this case, there is an important sign here. The nucleus is rotating fine, but here we'll notice an attempt was made using a blind chop. This always advise against this to my resident. Ki whenever you are doing phaco emulsification, that tip should be visible to you. That here the tip is covered by your completely nucleus matter, and you don't know where you are giving the phaco. So the moment you give a phaco, you might have hit the posterior capsule. Now you see the nucleus which was rotating fine is coming back. So this is a early sign, and this is tilting of your one pole of the nucleus. So this is another sign of PCR. So whenever such thing happens, the nucleus is large. Here the surgeon was quite aware, and the wound was enlarged and the nucleus was delivered. So this is the right thing. At times we get a lot of referral where the surgeon, they don't have a good vitrectomy cutter. So doing manual vitrectomy with one scissor is not a problem, but in such cases you should always use tricot in the end, because manual vitrectomy may not ensure complete vitrectomy. Once the vitrectomy is done, as I said, depending on the sulcus availability, you can always put a 3-piece IOL in the sulcus. That's not a problem. Once nuclear emulsification is done, normally we become little relaxed during the IA. This is a video, and I have shown this video almost 8 to 10 places, and I still don't understand the psyche of the surgeon behind this procedure. Okay, so I missed that. Okay, here you can see it's a hybrid form of IA being tried. There was no cortical fiber at all. There was one single band, and the surgeon was trying to pull that, and the patient squeezed the eye test on the topical anesthesia, and there was a huge PCR. So even if you are taking out the last fiber, you should be careful. IOL insertion, again, you should be careful about injecting the IOL. This is a case where there was extreme pressure, and the chamber was completely airtight with fully loaded with Hilon. So the IOL doesn't have a space. When it went into the went behind the PC, and when the IOL was attempted to retrieve, there was a huge PCR. So you should be careful. The message is that you should be careful at each step. This chart I have already shown you how to manage. Last thing I would discuss and then end my presentation is IOL implantation. It was a patient referred to me next day only by one of my fellow with a PCR and a IOL put in the sulcus. However, you can see the IOL was not in the right position, and the only thing I did was I released the vitreous from the wound and did a good vitrectomy, and the IOL was perfectly in the sulcus. So don't be in a hurry. If you don't have a vitrectomy facility with you, don't be in a hurry to put the IOL. You can always refer it to some of your senior or some higher center, so that the IOL implantation is proper and doesn't land up in more complication than what is normally expected from such complications. So with this I'll conclude here. So don't panic, check your instrument, maintain the capsular integrity. Residual lens matter should be removed, and use tricot whenever you feel vitreous is some vitreous fiber is still there. Try to protect the endothelium. So no heroics, no knee-jerk reaction. Follow normal principles how to manage, then you won't have any problem of dealing such cases. Okay, so I think I missed one slide. So as sir introduced, I am the current secretary of DOS, and we are doing a DOS midterm conference on 11-12 October. I invite you all to be a part of that program. Thank you so much.
Very good. Anybody who's not had PCR in this audience?
Everyone.
Few years back in IRSA meeting, I presented in Amritsar only, when Sardarji put up his hand and said, I have not had PCR. Then we found he was an ENT surgeon. He's come there because his wife was an ophthalmologist, and he was sitting there, and he has not had. So only if you are an ENT surgeon, you will not have PCR. Gynecologist also, correct. Wonderfully done, PCR, yes.
Okay.
Thank you, sir.
Thank you so much,